All right, greetings everyone, and welcome back to the third week of Indo-Anesthesia. Yesterday we have a lot of interesting sessions. If you can remember, we had talked about dexmedetomidine, few little about critical care medicine. So for this morning, we also have a special session in the field of intensive care medicine. We will also talk a little bit about the COVID-19 as well. And also, I would like to greet all the participants who already joined us this morning. I think until this morning, we have seen more than 3,000 registrants already coming from more than 70 countries. Welcome to Jakarta. And so also for this morning sessions, I would like to thank Pfizer Indonesia for sponsoring this and supporting this session. To open the session, I would like to invite Dr. Frans Pangalila. He is the intensivist from the Mayapada Hospital and Royal Taruma Grogol Hospital from Jakarta, Indonesia. Dr. Frans will talk about fighting difficult pathogens resistance in the ICU. How should we do? For this morning session, Dr. Frans will talk in Bahasa to more of the Indonesians to understand better. Please, Dr. Frans, you may start.
Thank you very much indeed, Dr. Krisya, for your kindly introduce me. Is it my sound is quite clear?
Yes, doctor.
Okay. Good morning, everyone. First of all, I want to thanks to the organizer, the committee that invited me very, very important meeting, the Indo-Anesthesia 2021, led by Dr. Susilo and Dr. Eddie Haryanto, my two seniors in here. So my task is for the next 25 minutes, I want to talk about the fight against the very difficult bacteria in the setting of ICU. What can we do? But again, as mentioned by the official, that let me very pleased that I have to present it in Bahasa Indonesian language, but the material presentation will be in English language. I do hope that the special or participants foreign and the native speaker will be followed it. Okay, let me start with my first slide here. Krisa, please.
Yes.
Baik, terima kasih moderator atas kesempatan, dan pertama-tama saya mengucapkan terima kasih kepada panitia, dalam hal ini dipimpin oleh Dr. Susilo Chandra. Saya merasa suatu kebanggaan dan suatu apresiasi sekali bahwa saya bisa mengikuti sharing dalam acara meeting yang penting sekali, adalah itu Indo-Anesthesia 2021. Saya akan membawakan topik untuk fighting difficult pathogen resistance in ICU setting. How should we do? Itu kira-kira untuk sekitar 20 sampai 25 menit ke depan. Saya akan mulai dengan slide saya yang pertama. Ya, ini adalah slide secara global dan ini dipublish JAMA tahun 2009 oleh Jean-Louis Vincent. Dalam EPIC study yang kedua, di sini kita bisa lihat bahwa sejak data diambil dari 2007 sebenarnya, 2009, bahwa sejak 2007 sudah adanya suatu didominasi dengan kuman gram negatif di ICU, dan hampir sekitar 30% itu adalah multi-drug resistant pathogens, dan kita bisa lihat di sini yang paling banyak adalah Pseudomonas. Dan sebenarnya 3 tahun kemudian, ITSA sudah membuat suatu warning atau suatu peringatan melalui public policy-nya, itu bahwa kita ini sedang menghadapi apa yang disebut perfect storm. Itu dimana disebabkan oleh kuman-kuman yang seperti yang dikatakan multi-drug resistant, itu MRSA, vancomycin resistant enterococci, MDR baumannii, dan seperti kita lihat ISBL, dan Carbapenemase enterobacteriaceae. Dan itu tahun 2011 sudah dilaporkan, dan kita bisa lihat di sini populasi Asia pun kita temukan bahwa kecenderungan peningkatan daripada resistensi daripada MDR daripada Baumannii, Acinetobacter, dan kita lihat di India 1 dari 4 dari isolasi itu adalah multidrug resistant Acinetobacter. Di South Korea begitu juga, ya, bahkan sudah extremely drug resistance. Dan di Cina hampir 30% secara umum sejak tahun 2008 sampai 2013 didapatkan 31% oleh Acinetobacter Baumannii. Dan ini menunjukkan bahwa kecenderungan peningkatan daripada bukan hanya multidrug tapi sudah extremely drug resistance. RASI itu adalah Executive Director MEA, yaitu Badan Pengawas Obat-obatan di Eropa, itu sudah mempublikasi bahwa adanya perbedaan mortalitas yang sangat signifikan apabila kita menangani pasien dengan resistant strain dengan yang sensitif. Itu signifikan perbedaannya dalam segi mortality. Kita bisa lihat di sini, misalnya pada Baumannii 16,4% akan mengakibatkan kematian, sedangkan yang sensitif 5,4%. Saya kira ini adalah logis bahwa resisten ini sangat mempunyai kemampuan yang bertahan terhadap beberapa kelas daripada antibiotik. Bahkan disebutkan juga per tahunnya ada kira-kira hampir 25.000 ekstra kematian akibat daripada multidrug resistance. Dan ini sejak tahun 2012. Tahun 2014 ini suatu review antimicrobial resistance, ya, dari United Kingdom itu membuat suatu gambaran secara luas di seluruh dunia bahwa kematian akibat multidrug resistance itu di tahun 2050 itu makin hari akan makin naik, dan kita bisa lihat yang paling tinggi itu adalah di Central Afrika dan di Asia. Ya, itu adalah negara-negara yang boleh dikatakan low middle income countries. Dan oleh karena itu kita bisa lihat sih dibuat secara suatu gambar bahwa 2050 hampir 10 million akan mengakibatkan kematian akibat antimicrobial resistance. Itu jauh lebih tinggi daripada penyakit kanker, penyakit metabolik degeneratif, maupun penyakit seperti diabetes, bahkan kecelakaan pun jauh lebih rendah dibandingkan kematian akibat antibiotik resistant, micro resistant. Dan kita bisa lihat di sini di gambar yang sebelah kanan ini, ya, hampir 10 bahkan lebih 15 tahun terakhir ini kita mengalami satu industri farmasi krisis. Artinya apa? Dalam 10 sampai 15 tahun hanya menghasilkan 2 sampai dengan 3 antibiotik. Sedangkan kalau kita bandingkan di era sebelum tahun 90, itu farmasi industri bisa menghasilkan sampai 15 bahkan 16 obat baru. Jadi seperti kita mengalami pada di era of no antibiotic. Ini persoalan, sehingga ini yang menjadi challenge kita sebagai klinisi untuk menghadapi. Di lain di sisi IMR makin naik, punya kontribusi terhadap kematian makin tinggi, pilihan antibiotik makin kecil. Oleh karena itu, apa yang harus kita lakukan di sini adalah ada beberapa step tentunya. Pertama itu adalah stop untuk melakukan iritasi terhadap bakteri. Kemudian lakukan appropriate adequate antibiotik sejak awal, sejak dini. Dan sebaliknya dilakukan deeskalasi dan bila perlu dilakukan pengobatan short course therapy. Jadi terapi jangka pendek, nggak perlu harus menunggu sampai 15 bahkan mungkin 20 hari. Dan yang terakhir lakukan optimalisasi penanganan infeksi kontrol. Tetapi pada kesempatan ini karena waktu sangat terbatas, maka mungkin saya akan lebih fokus pada early appropriate dan deeskalasi. Apa yang dimaksud dengan stop melakukan iritasi bakterial? Itu adalah yaitu gunakanlah antibiotik sebijaksana mungkin. Hindari misuse atau overuse of antibiotik. Dan kita lihat di sini bahwa berikanlah antibiotik itu hanya untuk infeksi, bukan inflamasi yang tanpa disertai didasari oleh infeksi. Ini yang penting. Sebagai contoh, misalkan jangan menggunakan antibiotik hanya sebagai antipiretik. Sebab ini sering kita dapatkan di lapangan bahwa begitu demam diberikan antibiotik. Atau kadang-kadang mungkin menjadi semacam anti-anxiety untuk dokter. Saya sudah berikan antibiotik, saya menjadi tenang. Ya, ini menjadi fenomena ini yang sering kita hadapi. Dan ini yang akan menginjus mutant resistance. Menambah kontribusi terhadap antimicrobial resistance. Oleh karena itu, kita harus hati-hati Nah, ini yang menjadi sedikit persoalan kita sesuai dengan topik kita adalah ICU setting, adalah spesifik populasi. Ya, ini sering kita temukan bahwa terutama kita tahu bahwa di ICU hampir 60-70% kita merawat pasien dengan severe infeksi atau sepsis. Ya, itu ada beberapa gambaran yang khas, yaitu adanya kerusakan daripada endotel, terjadi vascular leakage, dilakukan shock, dilakukan suatu resusitasi, menggunakan vasopresor. Kemudian tidak jarang juga pasien harus menggunakan invasive device, bahkan mungkin dia masuk dengan karena pasca operasi. Di sisi lain juga dia mengalami hipermetabolik, hiperkatabolik, hipoalbumin, malnutrisi, dan macrophage defect. Nah, kita tahu sendiri pada sepsis akan terjadi gangguan pada proses macrophage defect. Nah, endothelial dan peningkatan cardio output segala macam ini akan meningkatkan volume distribusi. Karena kita lakukan resusitasi, clearance akan meningkat. Apa akibatnya? Terjadilah penurunan relatif plasma daripada antibiotik. Dan di sini kita perlu adjust. Jadi misal kalau kita menggunakan kelompok time dependent atau misalnya contoh carbapenem, kita harus kalau perlu harus lakukan loading dose, kemudian diikuti dengan pemberian infusion drip agar bisa mencapai pemberian sekitar 3-4 jam dengan harapan bahwa level plasma konsisten berada di atas MIC. Terus kita tidak bisa menggunakan antibiotik seperti pada yang dianjurkan di NIMS atau Compendium. Itu adalah dosis yang sangat standar yang dianjurkan pada pasien-pasien yang bukan dalam keadaan ICU septic. Di sisi lain juga kita tahu dengan menggunakan device alat-alat yang bersifat invasif itu akan merusak mukosa, terjadi imun defect, dan tidak jarang hampir 60-70% pasien dengan ICU datang ke ICU sudah menggunakan antibiotik, mungkin bahkan bisa 5-6 hari sudah exposure. Keadaan ini akan menimbulkan bakteri load akan sangat tinggi, MIC akan sangat tinggi, bahkan tidak mungkin sudah menjadi mutan daripada multi drug resistant yang menyebabkan infeksinya. Oleh karena itu dibutuhkan suatu early appropriate adequate antibiotik di ICU. Jadi kita tidak bisa menggunakan antibiotik yang dengan dosis-dosis yang biasa saja. Perlu dimodifikasi. Ini adalah satu penelitian, boleh katakan satu landmark study dari Anand Kumar. Ini adalah slide yang sangat baik sekali, dan hebatnya mereka bisa melakukan penelitian seperti ini. Kita bisa lihat ini terjadinya shock kira-kira setengah jam sampai di atas 36 jam. Dan kalau kita lihat, kalau kita berikan antibiotik early, antibiotik ya, itu survivalnya itu kira-kira hampir 80%. Dan sangat berbeda kalau kita berikan antibiotik appropriate setelah 36 jam, survival mungkin tinggal 20% katakanlah. Jadi ini persoalannya. Di sini bisa dikatakan setiap keterlambatan terutama setelah 6 jam mengalami shock septic akan terjadi penurunan hampir 8% in terms of the survival. Dan ini sekali lagi message-nya, the sooner the better untuk dilakukan antibiotik yang appropriate. Ini adalah beberapa review dari beberapa expert untuk menilai bahwa kita bisa lihat pada tabel yang berwarna abu-abu itu adalah appropriate, sedangkan yang tabel berwarna hitam itu adalah inappropriate. Dan kita lihat rata-rata pada appropriate hampir selalu mortality-nya itu kurang dari 50%, sedangkan kalau inappropriate akan lebih dari 50% rata-rata mortality-nya. Jadi inilah significant difference in terms of the mortality. Hit right fast kalau perlu. Ini satu penelitian juga yang oleh Morata tahun 2012, dia membandingkan ya pada impact pemberian antibiotik setelah 30 hari mortalitas. Kita bisa lihat di sini di mana pada kuman pseudoaeruginosa. Dia mengelompokkan kuman yang non-MDR, umumnya kuman-kuman yang saya sebut adalah jinak, diberikan appropriate agent ya sebagai kontrol. Dan kita bisa lihat sejauh sekalian, kalau kuman non-MDR relatif jinak tapi tidak diberikan antibiotik yang inappropriate, kematian menjadi naik 2 kali. Apalagi multi drug resistant tidak diberikan antibiotik yang tepat, angka kematian menjadi 4 kali lebih tinggi. Jadi sekali lagi sini message-nya, melakukan pemilihan yang tepat pada sejak awal dengan menyesuaikan sesuai dengan apa ya, dosis yang juga harus diperhatikan. Sebab tidak cukup hanya dengan appropriate, harus juga dengan adequat. Adequat artinya dosis juga. Nah, sekarang sering menjadi apakah saya harus berikan sebagai monoterapi atau apakah saya harus memberikan suatu kombinasi terapi. Masih terjadi perdebatan yang cukup ketat di sini. Tetapi ini ada suatu meta-analisis mengatakan bahwa ternyata ya kalau pasien dengan kritis, katakanlah dengan shock septic, tidak ada, semua mendukung bahwa pemberian kombinasi ini harus lebih awal, diberikan sebagai empirik dalam bentuk kombinasi, dan tentu diharapkan setelah 4-5 hari dilakukanlah deeskalasi. Jadi sekali lagi, kalau pada keadaan severe, critical ill, hemodinamik tidak stabil, pilihannya itu adalah kombinasi. Ini adalah pemeriksaan yang menarik sekali, sputogram. Sering kita sebagai klinisi itu ignore untuk itu. Hasil yang sangat simple, 2 jam kita bisa dapat. Kadang-kadang sputogram ini datang bersamaan dengan kultur yang sudah definitif, tapi setelah 5 hari. Dan kita bisa lihat di sini. Kita bisa lihat di sini, kalau pasien dengan shock septic, yes, itu kita tidak perlu ragu, ya, kita perlu kita perlu kombinasi, mungkin menggunakan yang stronger antibiotik, kalau kultur kita, lokal ekologi kita MRA cukup baik, mungkin perlu kombinasi. Tetapi kalau dia tidak shock septic, tapi punya risiko multi drug resistance cukup tinggi, peran gram stain ini sangat signifikan. Dan ini sangat simpel, dalam tidak sampai 2 jam itu hasilnya bisa kita dapat. Dan kita bisa lihat di sini, ya, apa gram positif bacilli, gram positif kokus yang cluster itu khas untuk MRSA, dan gram negatif yang rot. Ini very simple sebenarnya. Jadi menjadi arahan kita untuk memulai jenis antibiotik yang apa, itu yang kira-kira. Terus kita bisa lihat, kalau misalnya kita temukan gram negatif rot, ya mungkin kita perlu antibiotik yang bersifat menekan pseudomonas. Dan ini tidak susah untuk dilakukan, dan sekali lagi dalam waktu 2 jam. Dan kita bisa lihat dari analisa penelitian ini, ya, kita bisa lihat bahwa ternyata gram stain, gram positif kokus itu sensitif 84%, spesifis 80,6%. Jadi sangat cukup membantu kita untuk menjadi guidance untuk memberikan antibiotik. Demikian juga pada gram negatif rot, sensitif bisa 94,7%, walaupun spesifik 57%, membantu kita untuk memilih antibiotik yang mana yang harus kita pilih berdasarkan sputogram. Tentu kita harus pertimbangkan juga consider pada lokal epidemiologi. Makanya kita di sini perlu suatu epidemiologi yang sangat kuat. Kami sering masih mendapatkan, terutama ke daerah untuk tanya, di sana belum ada lokal epidemiologi, kultur bukan menjadi sesuatu kebiasaan, ini menjadi kesulitan, padahal ini sangat membantu. Oleh karena itu, kira-kira apakah yang menjadi treatment sebagai empirik pada severe infection, pada sepsis? Kita bisa lihat di sini, ini pada tabel yang warna hijau ini, bila kita dapatkan kelompok seperti ada underlying disease, severe immunosuppression, neutropenia, diabetes, gangguan ginjal dan liver, COPD dengan struktural malnutrition, elder people, 90 hari yang lalu menggunakan antibiotik IV yang broad spectrum, clinical criteria for shock septic, kemudian kita didukung oleh lokal data yang bisa mengakses kuantitas karbapenem sekian persen, E. coli, ya, dengan lokal data yang kuat. Dan jangan lupa, pada gambaran yang seperti pada tabel yang hijau ini, itu adalah risiko untuk MDR. Dan makanya kita lihat, kalau kita temukan keadaan seperti pada tabel hijau ini, makin banyak poinnya makin dapat, ya. Kita tidak perlu lagi kita gunakan harus backbone drugs-nya itu adalah ceftazidime, avibactam, meropenem, piperacillin, cefepime, harus dengan kombinasi. Apalagi kelihatan pasiennya dengan critical ill adalah unstable, menggunakan ventilator, Apache score di atas 12, 13 mungkin. Sebaliknya kalau tidak ada di antara kriteria yang di atas tadi dan tidak didukung dengan lokal data yang tidak terlalu kuat, mungkin kita bisa gunakan kelompok yang ini dan tidak perlu kombinasi, kecuali pasien dalam keadaan unstable atau menggunakan ventilator full control dengan PIP yang tinggi mungkin, ya ini diperlukan mungkin juga kombinasi. Seperti yang dikatakan pada 3-4 slide yang sebelumnya, bahwa pada kritikal sebaiknya kita lakukan kombinasi. Penting juga setelah kita melakukan early appropriate, lakukanlah identifikasi akan kemungkinan antibiotik it doesn't work anymore. Itu persoalan. Jangan menunggu setelah 7 hari baru, wah ini tidak berjalan. Itu very simple. Itu adalah kita melakukan pemeriksaan dengan clinical parameters, kita gunakan CPES, atau mungkin kita gunakan biomarker, procalcitonin atau CRP. Yang penting kita harus melakukan assessment day to day, ya, untuk melihat apakah antibiotik masih bekerja dengan baik apa tidak. inilah kira-kira misalnya CPS dengan menggunakan 5 variabel, terutama yang kita lihat kalau dia menggunakan misalnya pneumonia masuk, itu adalah PF ratio, kan kita bisa hitung setiap hari rasanya. Ya. Apakah PF ratio makin hari makin membesar, makin membaik, ya. Dan kita bisa lihat di sini, ya, penggunaan inappropriate therapy itu bisa kita lihat dari CPS. Pada penelitian Luna yang publish tahun 2006, dia melakukan VAP, ya, pada diawali sejak min 3 sampai diagnosa VAP sampai plus hari ketiga. Dan kita lihat, ya disebut VAP pada hari 0 itu setelah didiagnosa adanya kultur. Dan kita bisa lihat di sini dengan penggunaan kita yang tepat, appropriate, adekuat, kita bisa lihat CPS-nya akan cenderung turun. Berarti ini berada dalam on the right track. Tetapi kalau CPS makin hari makin naik, ya mungkin ini kita harus melakukan adjust, ya. Dan kita bisa lihat dengan menilai CPS kita bisa mempredik, ya. Dan ini jelas kalau kita menggunakan appropriate itu adalah kematian itu adalah hanya 29%, sedangkan kalau inappropriate bisa mencapai 75% hanya dengan kita betul-betul ada perhatian untuk melakukan monitor misalnya salah satu CPS. Ya. Kedua, misalnya procalcitonin bisa. Kita bisa lihat procalcitonin dalam 72 jam bisa mempredik bahwa antibiotik yang mungkin kita berikan ini tepat atau tidak. Ya. Kalau dalam waktu 72 jam PCT kecenderungan makin naik, ya, kemungkinan terjadinya fatal outcome itu bisa 36%. Saya gunakan yang sudah validasi cohort. Ya. Sebaliknya kalau PCT-nya turun lebih dari 80%, berarti kita berada dalam jalan yang tepat. Artinya penggunaan salah satunya penggunaan antibiotik itu adalah pada pilihan yang tepat. Dan itu fatal outcome-nya hanya 8,8%. Oleh karena itu sekali lagi misalnya procalcitonin ini akan sangat membantu kita untuk membuat satu assessment apakah kita harus melakukan satu adjustment atau tidak. Algoritma itu yang dikatakan hit hard big dose kalau perlu kombinasi, tapi cukup dilakukan deeskalasi kalau bisa. Ya, intinya contohnya pemberian empirik, lakukanlah kultur sampling, ya. Kemudian dilakukan assessment 48 sampai 70 jam dengan melihat fisik diagnostiknya, hemodinamiknya, ventilator bisa kita lakukan weaning, fraksi oksigen bisa kita turunkan, atau vasopresor bisa kita turunkan, PCT cenderung turun, ya. Dan ini kita lakukan bila terjadi perbaikan, ya. Seandainya tidak ada perbaikan, ya kita terus harus memikirkan, ya, apakah ini diagnosa kurang tepat atau mungkin ada yang kelewatan, terus kita perlu further investigation untuk melihatnya. Terus apakah wrong diagnosis, wrong organism, atau mungkin komplikasi. Tapi kalau kita dalam clinical perbaikan klinis dan kulturnya itu positif, lakukan deeskalasi. Jadi kata kuncinya di sini adalah kalau klinisnya perbaik, kulturnya sesuai, lakukanlah neurospektrum. Hindari penggunaan spektrum yang luas dan berlama-lama. Nah, persoalannya source course terapi itu it's really safe apa tidak? Ini persoalannya. Nah, ini adalah satu penelitian dari Sang Sastra, ini juga satu landmark study. Dia membandingkan VAP yang 8 hari dan yang 15 hari. Dan kita tahu bahwa VAP Central Acute Pneumonia hampir 70%, 67 kumannya adalah multi drug resistance. Dan kita bisa lihat di sini hasilnya. Kita bisa lihat dengan pemberian 8 hari dan yang 15 hari. Memang 8 hari itu sedikit terjadi kekambuhan terjadi 28% dibandingkan dengan yang 15 hari. Tetapi secara statistik tidak bermakna. Tetapi kita dapat bonus di sini, yaitu adalah apa? Mutant resistant itu jauh lebih kurang pada penggunaan 8 hari daripada kita gunakan yang 15 hari. Katakanlah yang 15 hari dia sembuh, tapi satu waktu dia mendapatkan satu pneumonia, sudah penyebabnya adalah mutant resistant akibat penggunaan antibiotik yang sebelumnya infeksi itu sekitar 15 hari. Tapi on top of that kita bisa lihat, ya, bahwa in terms of mortality dalam 60 hari tidak ada perbedaan bermakna antara 25 hari dan yang 8 hari dan 15 hari. Terus, at least kita melakukan penyelamatan dari save the pocket, save the planet juga. Ini satu penelitian juga, ya, dari Sawyer, yaitu pada complicated intra-abdominal infections. Dibagi dua grup, satu kelompok menggunakan 10 hari, dan yang eksperimental hanya 4-5 hari. Tetapi dilakukan source control yang baik. Dan kita bisa lihat di sini pada antara kontrol dan eksperimen, kejadian penyulit, antara dihitung semua probability of event itu tidak ada perbedaan bermakna antara yang eksperimental dan kontrol. Ya, bahkan di sini jelas dari segi outcome primer mortality maupun komplikasinya tidak ada perbedaan antara 10 hari dan yang 14 hari. Itu persoalannya. Jadi asal, nah ini yang tidak gampang dilakukan pada abdominal sepsis source controlnya. Ini salah satu, saya kira abdominal sepsis salah satu sepsis yang kalau source controlnya itu sangat adekuat, appropriate, antibiotik tidak perlu lama-lama. Baik, moderator, ini adalah slide yang terakhir. Take home point-nya adalah treat only patients that truly infected. Early appropriate adequate antibiotik, terutama di intensive care unit. Lakukan identifikasi apakah pasien saya ini high risk of emergency of resistant strain. Pertimbangkan lokal ekologinya dan lakukan dose optimalisasi berdasarkan karakteristik pada pasien populasi di ICU. Kita tidak bisa menggunakan pasien yang seperti di bangsal seperti biasa. Lakukanlah identifikasi awal apakah ada kegagalan daripada antibiotik. Artinya antibiotik ini kemungkinan tidak efektif, yaitu dengan clinical parameters atau dengan biomarker. Kita tidak perlu mengevaluasi setelah 6-7 hari baru dilakukan perubahan-perubahan. Ya. Dan lakukanlah deeskalasi, source cause therapy. Tentu untuk melakukan deeskalasi berdasarkan klinis, perbaikan, dan harus ditunjang dengan adanya ketersediaan sarana biakan kuman. Kalau tidak ada biakan kuman, kita tidak bisa lakukan deeskalasi. Dan yang penting juga protect pasien, hindari untuk terjadinya cross-kolisasi melalui melakukan optimalisasi infection control, misalnya hand hygiene, atau yang lebih dalam grup yang besar, antimicrobials. Mungkin pada kesempatan berikut kita bisa diskusikan. Demikian moderator atas presentasi saya ini. Terima kasih perhatian, mudah-mudahan bermanfaat. Selamat pagi.
Alright, thank you Dr. Frans for such wonderful presentations. So for the next speaker, I think I will allow Dr. Dita as the chairman to introduce all the speakers. We have 3 prominent speakers in the field of intensive care medicine. One, we have Professor John Marini from the USA, we have Professor Frank van Haren from Australia, and we have Dr. Rohit Agrawal from the Singapore. And please, Dr. Dita, you may start the session.
Okay. Thank you very much, Dr. Krisha. Good morning, everybody. Good morning, John, Dr. Frank, and Dr. Rohit Agrawal. My name is Dr. Dita. I'm the moderator of this session this morning, and we would like to have John Marini. We already know because he's very famous. He's a senior consultant in University of Minnesota, United States. So he will present the topics about COVID ventilations, what happens and why. So we would like to invite John Marini to start the presentations. Please, John.
Don't forget to unmute your mic, John.
Okay, can you hear me, Dita?
Yes, clearly, John.
Okay, I will start then. First, I would like to thank the organizers. I'd like to thank Krissa and Dita and my great friend Susilo for inviting me to Indoanesthesia 2021. We've all been through quite a lot with COVID-19, and one of the important features of its management is, of course, the ventilatory management, which I'll try to summarize my approach here. I do not have any financial relationships and conflicts of interest related to this presentation. Now, The question that you're probably thinking about is, should we change our general approach to ARDS when it's caused by COVID-19 pneumonia? The answer is both yes and no. It's no because the principles of lung protection remain the same. However, our guidelines and usual practices may not be appropriate at all phases. And that's a major point in my discussion. I'm going to talk about the novel characteristics of COVID-19 ARDS to some degree, and then talk about newer concepts in VILI, and try to relate those to managing CARDS, which is the moniker for COVID-associated ARDS. The most important feature of COVID-19 pneumonia is that it not only attacks from the alveolar side, from the airspace side, but also from the vascular side. This is not typical ARDS. No matter what people have written, I would disagree with them if they think this is typical ARDS at all phases. And let me try to explain it. In a beautiful paper, Ackerman and colleagues showed that endotheliitis, thrombosis, angiogenesis occur at various stages in COVID-19. And in the beginning, there is a dysregulation of control of blood flow in the lung, which relates to that endotheliitis. Later, a little later, thrombosis occurs. And in the latest phase, in those patients who do not recover, angiogenesis begins. And that relates to fibrosis. In a paper that I wrote with Dr. Gattinoni in JAMA last year, we demonstrated that there are areas of the lung which have emphysematous changes. There is an unusual amount of dilatation of air spaces in this supposed variant of ARDS. The severe CARDS with vascular thrombosis and involvement eventually encourages fibrogenesis. And this has got genetic predispositions, of course. Not everyone proceeds to fibrosis, but those unlucky few who do will have a lung that is very difficult to ventilate in the end stage. Lung fibrosis is an undervalued finding in COVID-19 pathological series. This was published in Lancet in July of last year, basically showing the fibrotic pattern that often develops in patients with end stage COVID-19. So COVID-19 ARDS characteristics include the following. Profound hypoxemia and infiltrates do qualify as Berlin-defined ARDS. I say that based on the 2012 definition of ARDS that emphasizes hypoxemia but not mechanics. As I mentioned, CARDS is not conventional ARDS. The early unusual features, and I emphasize early, are ground glass infiltrates at the periphery, gas-filled lungs, but severe hypoxemia nonetheless, relatively easy to ventilate and oxygenate. And that has implications for what we do with the ventilator. There is unusually slow resolution of respiratory problems in many of these cases, as we've found. And high ventilation requirements may not have respiratory distress, dyspnea, in the very earliest phase. Talk a little bit about that as we proceed. Endothelial, the vascular manifestations, are, at least in the beginning, greater than the epithelial or airspace flooding manifestations. Later, it morphs into conventional ARDS, but not from the beginning. The hypoxemia due to VQ mismatch is greater than shunt, at least in the beginning in these patients. There's a tendency for rapid deterioration, and some have attributed this to cytokine storms occurring. Well, possibly, maybe not in the lung, however. I will talk just a moment about the shrinking baby lung and progressive power concentration that may help to explain why these patients go from looking relatively good respiratory-wise to severe deterioration. There is a high incidence of ischemia and thrombosis in the lung, as well as the liver and kidney, and this tends to generate more dead space than we're used to seeing. A protracted ventilation course is predictable. So this is a Wall Street Journal article that was published, and I was interviewed for this one. They basically said that, look, doctors are not agreeing on how we should be treating these patients with COVID-19 ARDS. And why is that? The stimulus for the heated controversy was this paper by Luciano and colleagues, saying that there might be different respiratory treatments appropriate for different phenotypes of COVID-19 pneumonia, which only later was described as being a time-dependent phenotype. In other words, the early phase of COVID-19 pneumonia varies from the late phase, and we'll talk more about that. The L type that they described was earlier and milder, and that progressed to a later type, which he called the H type, which was more severe and more typical in performance to usual ARDS. If we look at the hypoxemia alone, both qualify as ARDS, but the gas space is much different, as is displayed on the CT depiction on the right-hand side of this slide. In fact, the compliance of the lung, initially pretty good, evolves, and a standard type of ARDS does emerge, and later ends up with a restrictive disease. The L to H transition occurs over the course of the disease, and this is what has been confusing physicians. They say it's not a good compliance condition, but a bad compliance condition if they look at the late phase. And that is often the case in patients who are admitted to the ICU after 7 or 10 days of illness. So the COVID phenotype progression goes from type L to type H. Initially, non-invasive support is perfectly appropriate. If that does not hold the line, however, then early intubation may be appropriate with modest levels of positive end expiratory pressure. Then they enter the phase of ARDS, where there's more edema, higher PEEP is appropriate, prone positioning is appropriate, and in some cases ECMO, extracorporeal membrane oxygenation. And very late, there's very high elastance and other characteristics. And actually in the late phase, as in the early phase, high PEEP is probably not important and not helpful. It can actually cause more problems than good. This is a pretty typical example of early phase CT, ground glass, and crazy paving. You can see that the peripheral infiltrates are well defined, but there's plenty of gas in this lung despite the hypoxemia. This paper by some quite good investigators and people who are highly respected said that, it is just simply ARDS. Take a look. Here's the CT scan of those patients. This is late phase CARDS. Note that the PEEP average in this particular paper was 18 centimeters of water, and the mortality rate was 45 to 50%, much higher than it subsequently became. If you apply such high PEEPs to a lung like that, what do you expect? There will be problems. You may recruit some tissue, but you'll overdistend much more. If you look at ARDS and COVID-19 ARDS, or CARDS, and look at the tissue involved in both, the distribution is dependent in both ARDS and CARDS. but the gas volume is evenly distributed in early COVID-19. That's unusual for standard ARDS, and it has implications. This is a paper I contributed to with David Chiamello and Luciano. If you match ARDS patients based on their P to F ratio, their oxygenation, if you look at ARDS patients of the typical type, there's a fairly linear relationship between venous admixture and non-aerated tissue fraction. But that does not exist in CARDS, not even, and if you compare it with a compliance-matched ARDS, again, that type of ARDS does have a relationship between compliance and venous admixture, what that CARDS does not. And that's partly due to the endotheliitis we've been talking about that disrupts oxygenation in both phases. Given those atypical features, should we follow the standard rules in managing CARDS? Bertrand Russell said it best when he said, the whole problem with the world is that fools and fanatics are always so certain of themselves and wiser people so full of doubt. If we look at papers that have been published by some very good people, they've all been criticizing the idea that we should be thinking differently about CARDS. In fact, here was a fairly recent comparison between COVID-19 ARDS and classical ARDS, and they looked at compliance, the static compliance, and CARDS had a higher COVID-19, it had a higher compliance marginally on average than classical ARDS, but we have to take into account the timing of this comparison. COVID-19 compliance is not typical for standard ARDS. Compliance in milliliters per centimeter of water, this being about 50, it has many cases that have better compliance than 50, which does not indicate that you have a standard form of ARDS. Is it typical? Eventually, as I said, in the mid-range of that time distribution, it may be, but in generally, no. And what does that imply about how we should use PEEP? Well, normally, our familiar effects of PEEP, when we recruit, we reopen the vascular bed, we have better oxygenation, less hypercapnia, and less villi risk. If we do not recruit, we increase the pulmonary vascular resistance and overdistend and increase stress within the lung in a non-beneficial way. So recruitment is very important. In early COVID-19, and I emphasize again, early COVID-19, you have both standard effects and the effects that we don't want. There is some tissue, of course, that recruits. There's a reopened vascular bed, better oxygenation, but also overdistension. And that overdistension redirects blood flow into the consolidated tissue, increases the dead space, and disrupts the gas exchange profile. So we take issue, and we have done this in print with some of my respected colleagues who say that a different approach is not warranted. But if that's the case, at least in the United States, these tables that use PEEP levels, even the lower PEEP higher FiO2 table indicates a PEEP level that we think is not appropriate for the early phase of this disease. In fact, I wrote about this with Phil Dellinger and Dan Brody. We called it the confronting the COVID-19 elephant in deference to the fable of the blind man and the elephant, trying to piece it all together as it evolved and world experience evolved. We think that the way it does hold together is the early phase has better lung compliance, ineffective recruitment in the sense that there's not a lot of tissue to recruit, atypical PEEP responses, ventilation perfusion mismatching, gas-filled lungs, ground glass infiltrates, adequate organ function, limited inflammation, and some have even suggested immune suppression. As the problem progresses, you have standard ARDS, and then later, worse lung compliance, usual PEEP and prone responses in some patients, etc. All the familiar features. I do emphasize that at the very late phase, increasing PEEP is probably not the thing we should be doing, and proning may not be appropriate in the very late phase. Why do we disagree about the compliance? I've already mentioned. It's the time factor. COVID lungs early on are relatively compliant but oxygenate poorly. Higher PEEP levels geared to oxygenation overdistends and leads to low compliance. If you measure compliance at the PEEP that you're using and the PEEP is too high for the lung that you're distending, you're going to have low compliance. It doesn't have anything to do really with the resistiveness or the poor compliance of the tissue itself. It has more to do with how you're applying your therapy. Later, there's fibrotic contraction, which leads to low compliance, and impaired mechanics catch up to the impaired oxygenation that was there from the start. Other controversies that we should at least touch on that relate to ventilation is patient self-induced lung injury, known as PSILI, relevant to CARDS, and should we delay intubation? Well, there are three primary determinants of VILI risk as we currently understand it. You have to have damaging energy per tidal cycle, and you need to have high stress in those tidal cycles. You need to have enough of them per minute, and you have to have a long enough duration. And this is the mechanical stimulus for ventilator-induced lung injury. Unlike pressure, which we've been concentrating on with plateau pressure and driving pressure, the shrinking baby lung concentrates power. In other words, apply the same pressure to a big lung in a smaller lung, and you concentrate the power into the aerated space as the lung shrinks. Now, if power is really an integrating indicator of the stress and the potential damage to the lung, as soon as you start injuring the lung, then it becomes more susceptible to further injury. And it's very much like this situation where you have multiple fibrillar elements supporting the alveolus, and eventually, like a fraying rope, they break, and they break more quickly when the rope is already partially frayed. An intolerable strain on weak matrix fibrils reloads the ones that are left with a higher strain. In this image, which I don't want to take time to go through, basically it puts that shrinking baby lung concept into context. You have a fibrillar structure supporting the lung units in the matrix. Some of them break. They cause the others to strain more. Their baseline strain is more, and so is their dynamic strain more. And they break too. And eventually you have a fulminant ARDS, a quick process that we mentioned before can often happen in CARDS. We called that the VILI vortex: intolerable fibril strain, progressive stress loading, unit dropout, increased ventilation load, increased specific power, and a quick deterioration. So then you have to ask yourself, when is it best to intubate COVID-19 pneumonia? This, from a very old quote, is worth thinking about. The abuse of a thing is no argument against the use of it. In other words, you don't want to go too early. You don't want to go too late. Happy hypoxemia, we've all heard that expression. Most patients do not need intubation. I emphasize that. You don't intubate everybody who's hypoxemic. Happy hypoxemia occurs less often in those with severe impairment, however. And for those people, you better think about early intubation, or else you will generate P. cili and the shrinking baby lung. If the patient remains comfortable, stable, and or improving, less is often more. I have no arguments with that. But sustained high breathing effort and refractory hypoxemia is another story. This will eventually be a very long haul. The patient may fatigue quite quickly and suddenly deteriorate. Some have suggested that an earlier tracheostomy for overwhelmed ICUs during the surge that we've seen in a couple of waves might be a reasonable thing to do in such patients, because they will take a long time, and you do need to migrate those patients from the ICU to a less intense setting, so you free up beds for other patients. Vigorous breathing increases the transpulmonary pressure and violates the objectives of lung protection. And in COVID-19 pneumonia, this is from the JAMA paper I mentioned earlier, the villi vortex is amplified by the vessel stretch, increased edema, and power concentration effects, so that the hypoxemia can rapidly accelerate. And if you intubate too late, you will need higher PEEP proning and probably ECMO to salvage these patients. The reasons not to allow strong spontaneous breathing, in other words, to intubate, is obviously to improve oxygenation, but to also reduce oxygen demand and FiO2 requirements that have potential to injure the lung and reduce the villi risk by taking control. Over time, the risks increase if you delay intubation. We've talked about this before. And in putting it all together in the management of COVID-19 respiratory distress, you need to think about different factors. Before intubation, during mechanical ventilation, after intubation, and during weaning. The respiratory support options are many. The rationale is based on trying to prevent the deterioration according to the principles that I've just mentioned. So our takeaway points for ventilating COVID-19: prevent vigorous breathing and high transpulmonary pressures, reduce ventilatory demand, try to avoid intubation, but intervene early if efforts remain vigorous and the patient is dyspneic. Avoid high PEEP in the early phase and the very late phase, when the fibrotic process makes the lung very refractory to PEEP, and you just simply increase the stresses on the remaining lung. Prone positioning is a better option through most phases of ARDS. Monitoring mechanics and ventilation efficiency makes sense to personalize ventilation and avoid the PEEP tables and other usual guidelines for tidal volume sometimes, because if you look at the pressures that are developed by a tidal volume that satisfies the patient when they're not really they're in their earliest phase, you may not have plateau pressures and driving pressures that enter the high stress range. Prepare for the marathon, not a sprint. Avoid sudden changes, wean carefully, have a low threshold for anticoagulation in the beginning, and an earlier tracheostomy for overwhelmed ICUs is a questionable recommendation. So with that, I'd like to say, Terima kasih.
Thank you so much, John, for your very nice presentations. We always thank you for your time, because we know that it must be very late in the United States.
No.
It's around 10 a.m. at night, right? Yeah.
10 p.m.
10 p.m. Yeah, 10 p.m. Yeah.
Yes,
Thank you so much.
Right. Yeah, you're welcome. And I will stay for questions at the end if necessary. Okay?
Okay, we will have it. So we would like to invite the next speaker, Professor Van Haren. He is a senior intensive care physician in Australian National University and professor at the University of Canberra, Australia. Professor Van Haren, you may start your presentations. Thank you.
Just trying to share my screen. One moment. Try again. There we are. All right. Can you hear me okay, everyone?
Yes.
Can hear you.
All right.
Thank
Frank,
you.
can you swap displays?
Yes, I can.
Yeah,
Is that better?
fantastic.
Yes.
Okay, that's great. Well, thank you very much for inviting me again to talk at Indoanesthesia, and good morning, afternoon, or evening, everyone, depending on your time zone. And thanks very much, John, for a really excellent talk on COVID-19 and on the specifics of COVID-19 ARDS and how to ventilate these patients. I think it's quite a challenge in the real world, how to do that best in these patients. I would like to concentrate today on other COVID-19 therapies, so not so much mechanical ventilation and supportive care, but what specific COVID-19 therapies are there? I have no relevant disclosures for this presentation. And I'd just like to start by taking you back quickly to where it all started, this timeline of COVID-19, where, as we all remember, the end of December 2019, the first 4 cases were identified in Wuhan, reported, and then things went very rapidly because within a week or just over a week, the sequence of this coronavirus, the genetic makeup of this coronavirus was already submitted. So we already knew exactly what type of virus it was. A couple of weeks later, again, within a month of the first cases described, we knew that we knew how the virus gets into the body, that it needs the ACE2 receptor. And that's important for my talk later. This is how the spike binds to the epithelial cells and enters the cells and infects patients. So that was already very quickly determined. And then, of course, human transmission became clear, and we all know what happened after that. The pandemic has been absolutely overwhelming healthcare systems in many countries. And as of yesterday, according to the WHO dashboard, there have been 112 million confirmed cases. So these are confirmed cases. There are probably many, many, many more cases that not necessarily have been confirmed, and more than 2.5 million deaths already. When you look at the response of the scientific community in trying to come up with treatments and trying to get a better understanding of COVID-19, it is quite amazing to see that when I looked yesterday, there have already been 107,000 articles been published on COVID-19. And remember, we only know about this disease for just over a year. 488 clinical trials have been published. Of these clinical trials, 260 are randomized clinical trials. So there has been a huge amount of research. There is still a lot of research going on. When you look on the clinical trials registry, clinicaltrials.gov, there are almost 5,000 listed COVID studies, with almost 2,500 studies currently recruiting. So we still are going to get a lot of new information in terms of COVID studies and research. Of course, we know how to stop the spread. There's a couple of simple things that are very effective. I'm not going to talk about that too much today, but hand hygiene, of course, keeping your distance, and of course wearing masks. That is, if you actually put it in front of your mouth, of course, unlike Mr. Trump here. All these things help the prevention of spread of COVID-19. One other thing that I want to quickly mention, we have a lot of high-level talk about COVID and treatments and mechanical ventilation, but just some basic facts. What a lot of people don't realize is that the most common COVID-19 symptoms are still not actually that common. So only about 50% of people with COVID-19 develop a cough, less than 50% develops a fever and headache only in 35%, and even less common symptoms such as the loss of taste and smell. When you have that, it's a good signal that something is wrong and that it could be COVID. But if you don't have that, you still can have COVID because it's not a very sensitive test. So the disease spectrum was quite early on clearly described by the Chinese CDC, where they looked at a huge number of patients, 72,000 patients with COVID-19. And as we know, the majority of people get a mild disease. This can be asymptomatic without symptoms or just a mild pneumonia. About 14% get severe COVID-19 and often needs to be admitted to the hospital for that. And then about 5% of all will develop critical disease needing intubation and mechanical ventilation with a relatively high mortality when you get to the critical COVID-19 disease spectrum. We know that there are a number of risk factors for severe illness, including the elderly, obesity, and pre-existing heart and lung diseases. John has already shown a lot of very good pictures of ARDS or COVID-19 pneumonia. This was one of the early pictures that was posted online. So on your left-hand side, a normal X-ray, and the right-hand side, a typical COVID-19 pneumonia. And COVID-19 pneumonia and COVID-19 associated ARDS is not very common, as I said earlier, but of patients needing to be admitted to hospital, up to 25% requires mechanical ventilation, and the mortality is high. It's not as high anymore as it was before, because we have a few treatments that have shown to reduce mortality, but it's still high. And as John also pointed out, there is a high incidence of clots in the lungs and perhaps an unusually high compliance early on in the COVID-19 associated ARDS. Now, to know what treatments could be effective, we need to go back to basics and need to understand a little bit about the pathophysiology of COVID-19 lung injury. And of course, it all starts with the virus getting into the cell. Now, I mentioned this ACE2 receptor before. The coronavirus, the SARS-CoV-2, binds to this ACE2 receptor that is widely expressed in the lungs. It's on epithelial cells, in the alveoli, but also on the bronchial epithelial cells, and it's also on arterial and venous endothelial cells. So this is where these spikes of the virus, the spike protein, attaches to, and then this is how it's getting into the cell. It already has a direct effect that causes lung injury, because so-called ACE2 hijacking prevents the normal angiotensin II degradation. And because of that, there is an increased degree of vasoconstriction and lung injury, including endothelial injury happening. So this is the first step. Then another important component of the whole COVID-19 lung injury is, as John pointed out as well, is coagulation, coagulopathy. And this is quite significant. It is happening both within the alveolar cells and in the blood vessels around the alveolar cells. So there is fibrin that contributes to clots in the microthrombi, and it also contributes to hyaline membranes that you see in the COVID-19 associated ARDS. So coagulopathy is an important part of the pathophysiology and may therefore be an important target for treatment. So we know from electron microscopic examination that fibrin, so this clotting mechanism, actually happens. You get fibrin strands that rupture into the alveolar space, and then that's an adhesive substrate for white cells, as they also come into the alveolar sacs. So this thrombosis, so there's hyaline membranes in the alveoli, but also actual thrombosis in the blood vessels in the lung, micro thrombi, but also frank pulmonary embolism, which is quite common in COVID-19. So significantly more coagulopathy, significantly more thrombosis, and significantly more pulmonary embolism in COVID-associated ARDS compared to non-COVID-associated ARDS. The third important part of the pathophysiology is the inflammation. So the macrophages that are in the lungs are being activated, and they then release lots of inflammatory mediators and perhaps a bit of a cytokine storm, as John mentioned as well, although that is not entirely clear how important that is in the lungs. So there's a lot of inflammation going on. There has also been the suggestion that there is a cytokine storm outside the lungs, which is still, I should say, controversial. My friends from the Netherlands, Matthijs and Peter, did this study and looked at the levels of cytokines in COVID-19 ARDS compared to other conditions, such as sepsis with ARDS, sepsis without ARDS, and others. And they found that, for example, on your left-hand side, TNF alpha is not actually higher. If anything, it's lower than in patients with sepsis and ARDS. The same goes for interleukin-6, and the same goes for interleukin-8 concentration. So these concentrations in the blood don't seem to be particularly high compared to other diseases that also cause cytokine release. The next phase that's also important to mention in the pathophysiology is the formation of so-called neutrophil extracellular traps, which is basically extracellular DNA of the neutrophils. This is highly toxic and causes more lung injury, and could also be a potential target for treatment. So when you take that pathophysiology into consideration, you can already easily come up with a number of different potential targets. Of course, vaccines could prevent getting sick. It's not really a therapeutic target, of course. You talk about prevention, but therapeutic targets could be antivirals that attack the virus itself. It could be anti-inflammatory drugs that stop that cytokine storm from happening. It could be anticoagulants that hopefully sort out these microthrombi and maybe also some of the pathophysiology of ARDS. And then, of course, you could give antibodies, for example, of people who've had COVID. They've gotten better, and maybe you can use their defense reaction to try and cure patients with COVID. So let's quickly list a number of things that have been tested, have been looked at, but don't seem to work very well and basically shouldn't be used in COVID treatment. Now, hydroxychloroquine and chloroquine, there have been, in fact, a large number of studies now that have looked at this. There is a lack of clear benefit. There is definitely some toxicity, and it's currently no longer recommended to use this for COVID-19. And of course, the former President Trump was a great fan of hydroxychloroquine, but he also said that it would be a good idea to try and shine a bright light inside the body, or maybe drink some disinfectant. And of course, he's not a doctor, and these were not very good pieces of advice, as we all know. Briefly listing a number of other treatments that have been looked at, have been tested, and that have not shown benefit in COVID-19. These treatments include vitamin D, azithromycin, and the middle, that is very difficult to pronounce for a Dutchman, but that also doesn't work. There's no efficacy, no benefit of using any of these treatments in COVID-19. Now, what about convalescent plasma? So, as I mentioned earlier, people who have recovered from COVID-19 and have made antibodies, maybe we can use the plasma with the antibodies of these people and inject it into patients with COVID-19. I mean, it's a very interesting thought, a very intuitive treatment. Early on, there was not a lot of evidence that it was working, and last year in October in the BMJ, it was stated that convalescent plasma is basically ineffective for COVID-19. Recently, like literally yesterday, I think, this paper came out. No, sorry, not yesterday. Recently, that's a different paper. Recently, where maybe there is a place for convalescent plasma in a very, very specific situation. If you could give it to elderly patients or otherwise patients at high risk of getting very sick, and if you can give it within 3 days of the start of symptoms, then maybe it improves some of the outcomes. Of course, the problem with this whole treatment is that it's not widely available. It's not available in low and middle income countries. It's very expensive. And the systematic review that came out yesterday, that was the one that I was talking about. This paper came out yesterday, an overview, systematic review, meta-analysis of all the studies that have been done with convalescent plasma treatment. When you add all these studies up, and you can see it's quite a significant number of studies, there is no change in mortality, no improvement in mortality in any of the studies. And also, there is no improvement in length of hospital stay or the use of mechanical ventilation. So this is basically good news, I think, for low and middle income countries, because it's a treatment that wasn't going to be widely available. It's very expensive, and I don't think we should be using it anymore. Remdesivir is one of the antivirals that has been studied widely, and remdesivir has a role, although perhaps we're still not entirely sure exactly which patients to give it to and when to give it. So a number of studies have been done, and remdesivir has a modest effect, not a large effect, but a modest effect in patients with moderate COVID-19. So when they're not too sick, specifically if patients are only on low flow oxygen. So if they're not yet intubated or not yet on high flow oxygen. So, they have severe COVID, but only need a little bit of oxygen. If you give these patients remdesivir, there could be potentially a mortality benefit. But again, it's relatively expensive. It's perhaps not widely available, again, low and middle income countries. And there are a number of questions remaining. So which patients really benefit from this? Probably not the sickest patients, only patients with modest to moderate COVID-19. We're not entirely sure how long to give it for, and there's still some questions about whether on top of steroids, which have shown to work, as I'll show in a second, whether there's an extra benefit of remdesivir on top of steroids. So corticosteroids, that's a definite yes. That's very simple. I think there's been a number of studies now. This was the rapid evidence appraisal by the WHO when the first couple of studies had come out, published in the JAMA last year in September, and combining the studies that gave steroids to patients with severe COVID-19, so specifically intensive care patients with COVID-19, there was a really important reduction in mortality in these patients. And of course, the day before yesterday, it's amazing, all this new information is coming out every day. But the day before yesterday, results from the recovery trial from the UK were published in the New England Journal of Medicine, dexamethasone in hospitalized patients. So the previous slide was a meta-analysis of critically ill patients in intensive care. And in those patients, it reduces mortality. This is a study in hospitalized patients, so it includes intensive care patients, but it also includes patients who are not in intensive care and not on mechanical ventilation. And it appears that that there is a benefit in all participants, but the benefit is still the largest when patients are on mechanical ventilation. So that is definitely the group that benefits from dexamethasone, but there's also benefit when patients are not yet on mechanical ventilation. So it reduced 28-day mortality. The mortality reduction is greatest in patients on mechanical ventilation, but the consensus is that we should give dexamethasone to all patients in hospital who need oxygen or more. And the other important take-home message is that it doesn't have to be dexamethasone. Most of the studies have used dexamethasone, but the studies that used hydrocortisone or methylprednisolone have shown a similar effect direction and effect size. So other steroids, other glucocorticoids are also can also be used if for some reason dexamethasone is not available. What about targeting interleukin-6? I showed you earlier that there is an increased cytokine release, although it may not be as big a storm as we thought originally. But interleukin-6 is involved with this whole process of COVID-19, lung injury, and also injury to other organs in the body. So maybe we can target interleukin-6 and block that, and maybe then there is less, inflammatory mediated damage to the lungs and to the body. Now, this has been tested in a number of studies, and at the moment, although originally observational studies suggested benefit, the randomized studies so far have not shown any clear benefit, and there are at least 5 RCTs still underway. One was just finished in the UK, which gives a slightly different outcome than the others. But I think when you combine them all, there is still not enough positive news to support the routine use of this interleukin-6 inhibitor. And it's, again, good news for low and middle income countries because it's an expensive drug that is not going to be globally available. What about anticoagulation? If the coagulopathy is so important and you have ARDS that's partly caused by this coagulopathy, you have microthrombi, PE, maybe we should give all our patients therapeutic anticoagulation. Well, that's been studied, and REMAP-CAP is one of the large worldwide platform studies that had one of the arms or one of the domains was therapeutic anticoagulation. A press release just 2 months ago was that they found no benefit and potentially increased harm in intensive care patients. So if you give therapeutic heparin to all your COVID-19 intensive care patients, there is more bleeding, as you would expect, but there was no clear benefit. There is potential benefit in patients who are not in intensive care, so hospitalized patients. This study is ongoing, but we've seen some early results that suggest that therapeutic heparin or therapeutic Clexane or something like that could improve outcomes in patients who are not in intensive care, who are hospitalized with COVID-19. Now, we have a different approach, and we're looking at also heparin, but we're looking at heparin inhaled, so nebulized, inhaled, that goes directly into the lung. And why are we testing it at the moment? So just going back to that slide of the pathophysiology, well, the first step is that the virus needs to get into the lungs by hooking up to the ACE2 receptor. Now, what my collaborators from the UK have found is that heparin is actually a very strong antiviral drug. We only know heparin as an anticoagulant, as a blood thinner, but heparin actually is an antiviral drug, not just for this virus, for other viruses as well, but specific to this virus, it hooks up to the spikes of the SARS-CoV-2, then the virus undergoes conformational change and can't hook up to the ACE receptor anymore and can't get into the cell. So this could potentially stop the virus from attacking the humans. Now, this has been shown in the lab, where unfractionated heparin has a very strong antiviral activity, much stronger than low molecular weight heparins, such as clexane, so about 100 times stronger. And currently we're testing viral clearance in actual COVID-19 patients. Now, we talked about the anticoagulation, we talked about the coagulopathy in COVID-19 associated ARDS, and of course, anticoagulation, heparin is a strong anticoagulant and stops, of course, this coagulation activation. Heparin is also an anti-inflammatory, and it stops or reduces some of that cytokine storm issue. It reduces the formation of these neutrophil extracellular traps that I talked about earlier, and it's a mucolytic as well. That's perhaps not as important. So, I mean, this is all theory, right? So this is the theory. We've published it last year that there may be a benefit from this heparin when you inhale it. Well, there's a bit more evidence now. So first of all, pre-COVID studies in the lab, in animals and in the lab, already showed that pulmonary coagulation, inflammation can be improved, and oxygenation can be improved by inhaling heparin. So this is preclinical evidence. Clinical evidence, still pre-COVID, before the pandemic, was similar. There's quite a number of studies that looked at patients with acute lung injury from burns or from other things that can cause ARDS. And in all these patients, there was generally the same effect, an improvement in the coagulation, an improvement in lung injury, and an improvement in some of the clinical outcomes. Just a few weeks ago, we published a large phase 3 trial in the Lancet, again before COVID, but this was in patients on mechanical ventilation who had ARDS or were at risk of ARDS. And what we found in that study was that lung injury improved, there were less cases of new ARDS, and there was a faster recovery with more survivors after 60 days. So there seems to be something there with heparin, inhaling heparin in ARDS, but this is not COVID, this is pre-COVID ARDS. So where are we at the moment? We've just submitted a paper where we treated 100 patients with nebulized heparin, 2 hospitals in the United States and 1 hospital in Argentina. And we found that this treatment is safe. It doesn't actually affect the systemic bleeding or anticoagulation status. There's no bleeding complications. And there was quite a significant signal, but this is a case series. It's not a controlled study, but there was a signal towards improved oxygenation, as can be seen in this graph. So this is the peripheral saturation to FiO2 ratio. The black line is all patients, and you can see they sort of are static for the first couple of days. Then they all deteriorated quite significantly. This is when the heparin was started at baseline, and then all patients show a general slow improvement, specifically the ones that were not intubated, but there's also an improvement that can be seen in intubated patients. Currently, we have a couple of hundred patients enrolled in 2 different meta-trials. So we do a meta-trial in a number of countries around the world in patients in the hospital, but not yet on the breathing machine. That study is called InhaleHep. And the outcome of that one would be intubation. So we're trying to avoid intubation with this treatment. And the second meta-trial is a meta-trial of patients already intubated and on mechanical ventilation, where the outcome is the duration of ventilation and mortality. So we don't have results just yet. We have some early results that are very promising, but we need to obviously finish these studies, because the only way to generate evidence really is by doing it in a randomized way. So we believe there is a strong rationale to test nebulized heparin in these randomized studies as we're doing at the moment, because the heparin is antiviral, it is an anticoagulant, it is an anti-inflammatory. We know that it's safe from previous studies and now also in our case series. And we know that from previous studies that it can have a positive effect on lung injury and ARDS. What I didn't mention, the other thing we're working on is community studies with nebulized heparin to see if we can stop the spread, for example, in healthcare workers, frontline healthcare workers, and care homes. So this is all work in progress. So to wrap up, ladies and gentlemen, what I would like to say is that, as I've shown, there's been an enormous outburst of research since COVID started. Not all research is fantastic research. There's a lot of non-randomized evidence that then was tested randomized in randomized studies and didn't hold up, and that's why we have to be careful as well with the message around nebulized heparin. There is no randomized evidence just yet. We're working on that, but it's quite promising. So there's an enormous amount of research. I think we have an improved understanding of pathophysiology, and because of that, we now have a limited number, but a number of effective treatments for COVID-19. And as I've shown, there are still many studies ongoing, and hopefully we'll have some more treatments available soon. I still think that treatments are important. Some people think that with the vaccinations now starting around the world, that COVID will disappear very soon. I don't share that view. I think it will be still quite a while before we have sufficient vaccination globally, at the global level, especially in lower middle income countries. That will take quite a while. So I think the search for effective treatments is ongoing and is still important. And with that, I would like to end my talk, and I thank you all very much for listening.
Thank you so much, Professor Van Haren, for your very informative presentations. It seems like the most therapy should be started earlier, to show the benefits before the patients fall into the more severe conditions, I think. So I would like to invite the next speaker, Dr. Rohit Agrawal, to present the topic fluid in septic shock when it's too much. Dr. Rohit is a senior consultant in Department of Anesthesia in National University Hospital, Singapore. Dr. Rohit, you may present your topics.
Yeah, thank you. Can you hear me?
Yes. Dr. Rohit, could you change your slide? Yes, yes, we can hear you, but could you change your slide display?
Yeah. Can you hear me?
Yes.
Yeah.
Okay, thank you. Yes. Okay, just a second. Can you, sorry, I'm not able to share my screen.
Yes.
Just a second, let me just start sharing again. Can you see my screen now?
Yes.
Yes.
Okay. Okay.
I think now it's in the presenter view.
Yeah.
Yeah.
Okay. So thank you very much. I would like to first of all thank organizing committee and Prof. Susilo to give me an opportunity to speak at this platform. Okay, myself is Rohit, and I'm practicing intensivist and anesthetist from NUH, as just now introduced. Today I will talk about fluid in sepsis. Okay, and this is just to give my perspective and backed by some evidence. It's unlike not related to the current COVID talks that we heard, an excellent talk by Prof. Marini and Prof. Frank. Okay, it is a little bit deviation from the current topic and a lot of physiology involved. I will use some physiological evidence to support my talk. Just to no disclosures pertaining to this topic. And this is the today's objective that I would try to achieve as we walk through some of the slides. I would like to use some of the hemodynamic basis to explain the effect of septic shock, as currently, though it has been widely assumed as hypovolemic shock, though we know that there are other components involved as well. And we'll just share how not only the hypovolemia, but other factors play an active role in when we are considering these patients for fluid therapy. I would discuss a bit more about early goal-directed therapy and why we are not able to achieve the same goal that we were able to show, or the effect that we were seen in the past, why we are not able to see the same effect of this fluid therapy in early goal-directed therapy when we are using aggressive fluid therapies in this patient. Is lactate a specific marker for septic shock, and is chasing the lactate worth our time and money? And finally, we'll share my practice and the evidence behind the current fluid therapy. Okay, hope. This is to start off with. This is a very basic oxygen delivery diagram from the physiological prospects. Okay, so as we can see, the oxygen delivery is depending on cardiac output and oxygen carrying capacity that is given by hemoglobin concentration and oxygen saturation. So we'll more focus on the left side of this. And as we know, the cardiac output is depending on the preload, afterload contractility, and supported by the optimal heart rate. So any effect, basically what is shock? Shock is basically inability of a cardiac output to maintain optimal oxygen delivery. And this is in the macro perspective. But in the micro, if you move down a bit, looking at the factors that control cardiac output, so any effect on the preload, afterload, or contractility will, in general, affect the oxygen delivering tissue oxygen delivery. So, as we know, any decrease in preload, which is commonly seen in patients with hypovolemic shock or ongoing GI losses, will lead to hypovolemic shock. Any increase in afterload, like in patients with massive pulmonary embolism, or patients with pericardial tamponade, will lead to obstructive shock. And any decrease in contractility leading to pump failure itself, like in patients with MI, severe MI, will lead to cardiogenic shock. All of these things, or any of these things, will lead to this decreased tissue oxygen delivery, which in turn will lead to decreased oxygen, without affecting the oxygen carrying capacity. It will decrease the tissue oxygen delivery and thus causing lactic acidosis. So lactic acidosis is basically is a surrogate marker or biomarker for inadequate tissue oxygen delivery or demand supply imbalance, which can be present in the varieties of the form of the shocks. Okay, so labeling it specifically to septic shock can be one of the concerns, or one of the factors which might have led to inadequate or over resuscitation of this fluid. In general, where do we think this septic shock can be placed in this whole context? So I would like to use another physiological diagram, and I will share how I look it a little bit differently. So this is basically a Guyton curve and a cardiac output, cardiac function curve overlapped. And this represents a normal physiological situation where with a right atrial pressure of 2 mmHg, with a normal cardiac function, a person is able to generate cardiac output of 5 liters per minute. And mean systemic filling pressure is basically a pressure which is exerted by the blood volume in a standstill circulation. So basically, it is a kind of an experimental in setting, but in the real life scenario, you can use it as a surrogate marker for the total intravascular volume. So this is my personal view, and I had extrapolated it to look at in different perspective. So venous return, as we know, is actually equal to cardiac output. And if you remember the previous flow chart just now I showed, the cardiac output is dependent on preload, afterload, and contractility. So to put the things in simplicity, or it's for the simplicity purposes, we can say that mean systemic filling pressure, which is a marker of intravascular volume in the standstill circulation, it can be a surrogate for a preload, and it is not only a volume, but it's also determined by the vascular tone or the compartment that it is filling in. Similarly, right atrial pressure, though it is a marker for the central venous pressure, but if you look at the factors that affect the right atrial pressure, it is the cardiac functionality and the cardiac structure which will affect the right atrial pressure. So we can use it as a surrogate for a cardiac condition in the context of cardiac output. And total peripheral resistance, though it is ideally a capacitance vascular system, that is a vascular venous system of the body, but it does affect it in the broader sense. You can use it to affect both preload and afterload. So as we know that the cardiac output is affected by the preload, contractility, and afterload. Similarly, the cardiac output or the venous return can be explained by the varying combination of mean systemic filling pressure, right atrial pressure, and total peripheral vascular resistance. Okay, I will just show you in the graph how septic patient behave and what happens to these parameters in a septic patient. So this is a hemodynamic effect. This is a graph, just will overlay on this graph what are the hemodynamic effect of the septic shock. So as described by Rivers et al. In the as early as 19th century or late mid-19th centuries, the shock patient with a decompensated shock present with decreased intravascular volume due to either actual loss of the volume intra-cell by vomiting, diarrhea, or some third spacing of the fluids in the patients with pancreatitis or peritonitis, and it's also associated with vasodilatation. So basically, there is a decreased intravascular volume, which is denoted by the lower mean systemic filling pressure, which in turn leads to decreased venous return and decreased cardiac output. So this is the patients who are in decompensated shock or just the beginning of the shock. However, with this onset, there is a compensatory mechanism which kicks in the body, which is associated with release of or activation of renin-angiotensin-aldosterone system, retention of fluid and electrolytes, movement of fluids from the different compartments like skeletal muscle and splanchnic circulation inside the vascular system, so as to maintain the mean systemic filling pressure and thus maintaining the cardiac output. So in real life scenario, where do we see these patients? It depends on where they are actually in the whether they are in decompensated or compensated phases of shock. Though in our setting, classically septic shock has been described as a compensated, where the cardiac output or cardiac index is really high and peripheral vascular volume is systemic vascular resistance is really low. So, but again, as I mentioned, like it is a whole spectrum, and then it can be varying. We also know that because of the sepsis, there is decreased or effect on the cardiovascular cardiac function by itself. Nitric oxide, which is involved in the vasoplasia, is also affects the movement of calcium within the cells in the myocardium, or which in turns lead to decreased systolic function, decreased systolic contractility, and inability of the myocardium to relax during the diastole. So in general, initially there is increased left ventricular and systolic volume, and also associated and left ventricular and diastolic volume. In general, the stroke volume is maintained, but the cardiac output or the cardiac index in this cases is maintained primarily by increase in heart rate, which is commonly seen in the patient with the septic shock. As the shock progresses, or depending on the patient condition, if patient has pre-existing myocardial dysfunction for some or the other reason, then this may end up in decreasing left ventricular and systolic volume, and patient may have a worsening cardiac output. So if we overlay the, so in addition to this, patient with a poor cardiac function may have higher right atrial pressure to start off with. As we can see from this graph, right atrial pressure is 2 mm of Hg with a mean systemic pressure of 7. So those patients who have a high right atrial pressure to start off with, the gradient between the right atrial pressure and mean systemic filling pressure is quite low. So the end result of the volume loading or compensatory or the inherent compensatory reflex in this patient will be not so high. The cardiac output generated in those patients can be still lower. As we increase the right atrial pressure further, either because of inherent cardiac condition or because of fluid loading affecting the right atrial pressure, it will further reduce the cardiac output. So when we overlay all this graphs onto the original curve, we will find that when we see the patient, our cardiac output of a patient can be anywhere from below normal to above normal, depending on where we are seeing these patients. So this is just another perspective to highlight what I'm coming to the next. So hemodynamic effect of the septic shock is multifaceted. Not only it's related to the hypovolemia, but there is significant cardiogenic component, and there is inherent activation or activation of the neuroendocrine pathway within the body, leading to the compensatory mechanism. And combination of all these three things will lead to the state of the patient where we see these patients at our ED or in the ICU or in the ward. So this brings me to this early goal-directed therapy. This is the first our bundle of early goal-directed therapy in patients with the septic shock. As I rightly mentioned, it's a medical emergency, and it requires a systematic and bundled approach to attain the best outcome for this patient. Again, as I mentioned, what we are talking here only about the one component of the therapy. The early goal-directed therapy is inclusive of diagnosis of the early diagnostic test, early therapy in the form of fluid and antibiotic, and monitoring in the form of lactate, cardiac output, and other things. Okay, what we are talking here only is about the fluid component of this therapy. So to start off with the timing, so 0 hour for this patient starts when the patient comes into the hospital. Okay, so it may be right to align ourselves in the management of these patients to put ourselves as a 0, but it's not a 0 hour for the patients with the who is already in the process of the sepsis for unknown period. So it doesn't take into account the pathophysiology or the type of the sepsis or infection that patient is already having, and the days that patient had spent outside the hospital when suffering from that sepsis. For example, a patient with pneumonia or patient with pancreatitis or peritonitis, when they are out of the hospital for 2 to 4 days, they are all treated in the same way. It's but however, the underlying process might have been in the varied stages that we had seen earlier. It calls for giving a fixed amount of fluid boluses to this patient. So, which again, for the above mentioned reason, and without taking into account the basic underlying original cardiovascular or the renal functions of this patient, may not be very optimal. And it uses lactate. I would say that lactate is a good marker to understand that the patient is critically ill, but to use that marker to treat the patient and to chase that marker so as to it become normal with our therapy may not be very optimal. And in subsequent slide, I would just share some of the same things. So as I mentioned, though fluid therapy or early goal-directed therapy has been shown to reduce the mortality since it has been introduced in surviving sepsis guidelines from 45% to less than 30%. But in the recent trials in last 1 decade, this prominent randomized controlled trials had failed to show this effect consistently. In general, the mortality mentioned in this group of patients, whether therapeutic arm or controlled arm, is lower than the overall mortality in the septic patients. So they're maintaining around 30% of overall mortality. So it's not to say that the early goal-directed therapy is not working, but there may be some other reasons that we need to critically analyze. So it may be that our practice in last couple of decades has changed so much that our baseline is now become equivalent to an early goal-directed therapy. That could be one of the reasons. The other reason which I could think about is, when patients in the early goal-directed therapy or the therapeutic arm may be getting unnecessarily excess amount of fluid, and which in turn will increase the mortality in those patients. So it could have been lower mortality, but it sort of skewed the whole outcome in favor of the control arm. So as we know, that early goal-directed therapy or excessive fluid given in this setting can be harmful, and it can, as shown in this study, like glycocalyx, which is originally in the septic patients is associated with original function of the glycocalyx is to act as an endothelial protective membrane, and with the activation of tumor necrosis factor, there is release of this heparinase, which causes degradation of this protective glycocalyx layer, releasing the heparin sulfate. So in this small study of 400 patients, they looked at the effect of or the amount of heparin sulfate in patients who have no infections versus a septic shock. And then they found that those patients with the severe septic shock had significantly elevated heparin sulfate, indicating that glycocalyx degradation is quite prominent in these patients. And not only in the septic shock patients, but also in non-survivors. As we can see in graph C on the right-hand side, the non-survivors had significantly elevated heparin sulfate in their circulation. So which indicates that there is damage to this glycocalyx, and which is proportionate to the degree of sepsis. So they went on to study the effect of fluid on this heparin sulfate in plasma. And what they found, that level of heparin sulfate is proportionately increasing with the amount of fluid given to this patient in first 24 hours, which again suggests that fluid itself can continue to damage glycocalyx and is leading to ongoing organ damage in this patient with the septic shock. How does the fluid damages the glycocalyx? That is something to think about. The author proposes that there is a shear stress, the similar thing that leads to the damage of the lungs. Similarly, when the fluids are given to these patients, the shear stress of the patients who had damaged endothelium lead to the further release of heparinase, causing the damage of glycocalyx in these patients. So shear stress exerted by the volume loading and also isotonic fluids activate the neutrophils directly, and which in turn can continue this process of damaging the glycocalyx and causing more harm than good. After we had given all the fluids to these patients, which not only is causing the ongoing damage, but they tend to remain in the body for the longer period of time, and which in turn can cause increased morbidity and mortality. So morbidity can be in the form of increased ventilators days stay, increased ICU stay, requirement of dialysis to clear of these fluids, inability to tolerate foods or the feeding by enteral route, or depending on the surgical, maybe there is a wound healing and all those things can be affected as well. And also it's shown to affect the mortality. In a small retrospective analysis, this group actually went ahead to see whether there is any further interventions required. And then they found that there is those patients who underwent early goal-directed fluid therapy has a positive balance in around 70% of the patients, and which remain positive up to a week in 50% of this patient. So this fluid, which was given in the acute phase, lingers in the body for a long period of time and causing more harm than good to these patients. So this patient, we know that they require fluid, and we are following what has been suggested. But is the parameters, or is the target that we are using, is it wrong? So I would just like to share something on the lactate. So
answering questions.
Sorry.
No,
Hello?
sir, you may continue, Dr. Rohit.
Yeah. So as we know, the lactate is a marker of imbalance of oxygen supply and demand, as we had seen it earlier. Okay, but other way to look at the optimal oxygen supply is to look at a mixed venous oxygen saturation, or to calculate the oxygen delivery by pulmonary artery catheter. And in this study, they didn't find any correlation between the amount of lactate and venous oxygen saturation. So ideally, if your venous oxygen saturation is low, or is a peripheral oxygen requirement is higher, as denoted by low venous oxygen saturation, your lactate should be higher, and it should decrease proportionately with the increasing venous oxygen saturation, which was not the case. And similarly, with increasing oxygen delivery, there should be decreasing lactate, again, which was not shown clearly in this study. Having said that, venous oxygen saturation can be a double-edged sword. Neither low nor high is very good, as we know that increased venous oxygen saturations can be suggestive of decreased utilization or shunting in the peripheries, which can be happening in the septic patients. So again, the point is that there is disproportion between the actual lactate and the oxygen delivery in this patient. Again, if we try to optimize, or we try to neutralize the lactate by giving excess amount of fluid, which may not be true as well. In the study conducted by Gattinoni et al., they looked at around 1,800 patients, and they tried to see the lactate trends. And then they found that though lactate is normalized, or lactate is reduced in around 50% of the patient, in another 50% of the patient, it takes around more than 24 hours to normalize, which is suggestive of non-perfusion related origin of the lactate. Though we want, as much as we want the lactate to be trending and follow path 1, as we can see here, but due to the other factors or changing patient condition, it may remain stagnant for a while before it continue to trend down. So this point brings us to the non-lactate origin of the non-perfusion related origin of the lactate, which is commonly seen in the patient with the sepsis. So in patient with the sepsis, there can be shunting, there can be activation of adrenergic pathways, renin-angiotensin aldosterone pathways, and also sympathetic stimulation, which in turn lead to increased glycolysis and stimulation of the sodium-potassium pumps. There is also infection can directly affect, or microorganisms and the toxins can directly affect the pyruvate dehydrogenase activity and can lead to mitochondrial dysfunction as well. Experimental studies have suggested there is increased production of the lactate beyond the consumption that can be consumed by the body in the lungs as well during this septic period. So, to summarize, that we know that our patients need fluid, and but however, using a fixed biochemical marker may let us to give this patients an excessive and uncontrolled amount of fluid, which in turn can remain in the body and can continue to cause harm in these patients. So, hence, I would like to share with you this an excellent article published in Annals, and which is also the way is I usually practice my fluid therapy in the septic patients, and the concept 4D concept. So what they propose is to use or consider fluid as similar to the drug, and then fluid should be under using with the same scrutiny as we use any of the drugs or antibiotics in the ICU. So fluid should be considered from the prospects of definite indication and contraindication. They should be given in specific dose with taking into consideration PK/PD of this dose. The duration should be identified, and when the time comes, then fluid should be taken down or should be removed from the body, leading to de-escalation. So I will just share a couple of slides on the fluid therapy. So as we know that there are different classes of the fluid, crystalloid versus colloid. So the studies have shown that as long as a patient is in the hypovolemic state, the membrane or the endothelial layers are not leaking, whether you are giving crystalloid or colloid, they tend to remain in the circulation for longer period of time. It is not only true for the patient with a septic shock, but in the perioperative time as well, when the patient has hypotension, the crystalloid or colloid can remain into circulation for a longer period of time. Whether you use lactate versus acetase depends again on the metabolic condition of the patient. And similarly, we know that we try not to use hyperchloremic solutions, which can lead to increased SIDs and thus causing more harm and renal dysfunction in these patients. Inappropriate therapy can lead to further worsening of acidosis, kidney injury, and may lead to difficult weaning from the ventilators. We need to definitely take into consideration underlying cardiac renal functions of this patient. I tend to use some of the albumin as the part of the resuscitation and also for the de-resuscitation. Though indication has been divided as 4 in this group, personally I use resuscitation, maintenance, and replacement fluids. Okay, and then resuscitation is only during the first 6 to 24 hours of the patient when they are in the acute phase. And rest of the time this patient is mostly on the maintenance phase. So it is very well established that early therapy with the fluid is very important, and delay in the fluid administration would lead to further microcirculation, hypoperfusion, and organ damage. But how long do we want to keep this acute therapy for? So Murphy et al. Has looked into different patterns of fluid resuscitation. So whether you want to give early aggressive versus early conservative fluid resuscitations for this patient, and late conservative versus late liberal therapy for the removal of the fluid. And what they had found out that early aggressive and late conservative has tend to have a lowest mortality in whole lot of the patient. So you tend to give early aggressive fluid therapy, you stop the fluid therapy, and then you try to keep the patient in some negative balance for next for consecutive 2 days in the first week while they are in the ICU once they are out of the acute phase. But however, when they combined data from some other studies, they found that even late conservative can be better than the early aggressive. So we need to be just optimal in the early phase, and while we want to be definitely conservative and stop giving the fluids in the later part when the patient continue to stay in the ICU. So how do you determine the dose? So to determine the dose, we need to take into account the PK and PD of the fluids. PK is determined by what body does to the fluid, how early they can get rid of this fluid from the circulation without causing harm to the body. And PD is the one which we try to focus in this a little bit in next couple of slides. So to determine the PD, we need to have some kind of targeted response. Your targeted response can be either biomarkers that we are currently using, like a lactate, or you can be a physiological biomarkers or dynamic biomarkers that more and more studies are coming out with. When we try to optimize the fluid therapy by giving and looking at the changes in the stroke volume variation and the cardiac indexes of this patient. So as I mentioned, like in the acute phase, the body tends to retain whether you give crystalloid or colloid. This is a small experimental study which is showing the same thing, whether you give Voluven or Ringer's lactate, and if given over a period of time, they tend to remain in circulation for almost the same duration. To determine how much volume to be given, we can use Frank-Starling curve as a therapeutic response curve for these patients. And we know there are different ways that we can give fluid boluses or fluid challenges and see the responses in different ways, whether there is a decrease in the stroke volume variation from 15% to 10%, or if there is a change with the end occlusion therapy or straight leg raising test. So if there is a response to the fluid in this with this therapy, then we continue to give these patients the fluid as required. And if there is no response, we know that the patient is on the this flat part of the Frank-Starling curve, and any amount of fluid will not cause any benefit to this patient. So to the last part, I think the de-escalation is as critical as early goal-directed management of the fluid in this patient. I prefer late conservative fluid management, and not all the patients, again, are able to move their fluids as suggested. So classically, it has been described as ebb and flow phase, but this ebb and flow phase can be prolonged and variable from patient to patient. And some of the patient may require some help during the late flow phase, where they are not able to get rid of this fluid by themselves. And these patients may benefit by the different drug therapy or the dialysis as required to remove this fluid from the circulation, so as to decrease their stay in the ICU and then decrease the ventilatory stay as well. So in addition to this, the fluid stewardship, we need to see which phase of septic shock the patient is in, whether the patient is in resuscitation phase or whether we have optimized this patient. If we continue to resuscitate this patient and patient is going into requiring or accumulating extra amount of fluid, patient may be suffering from this global increased permeability syndrome and may already have went into third hit of the shock. So we need to be very careful when we are giving the fluids and prevent the patient from going into this vicious cycle of ongoing shock, which may be more iatrogenic than actually disease related. So with this, I think I will just like to summarize. Early goal-directed therapy in septic shock, what is the goal? I think the goal should be individualized, and we should focus not only on the fluids, but also on the early institution of the inotrope for this patient. Hemodynamic effect of the septic shock is not necessarily hypovolemic, and it is combined effect, as we had seen. It's including cardiogenic and neuroendocrine, and it can be dynamic as well. It moves from one phase to another phase depending on the response of the patient and underlying condition. Lactate is definitely not specific, and it's multifactorial, and it may be more harm than good if we try to chase the lactate to the normalization with the fluid. We should incorporate fluid stewardship in our practice, and which should be guided by the preload responsiveness. There are a variety of devices available which can be used to look for the preload responsiveness and thus guide us in giving optimal fluid to these patients. Thank you.
Thank you so much, Dr. Rohit. So we enter question and answer sessions. So there is some questions that I resume. First for John, there is a questions that many COVID patients show that so-called happy hypoxemia. They look stable with high flow nasal canal or non-invasive ventilation, but unfortunately the lab findings show severe hypoxemia. So which one should we believe to decide whether we should intubate these patients or wait and see not to intubate these patients? And what do you suggest for the target of the oxygen saturations to start to intubate this kind of patients? Thank you, John.
Okay, Dita and the questioner, I think it's a mistake to target one specific value of any parameter or symptom, but the trend is extraordinarily important. If the trend with what you're doing is deteriorating, then I think that's the time to early. You know, it's not going to be an easy time with these people. It's going to last a long time. It's better to take control early on. Don't let them vigorously breathe so that it exacerbates the risk of lung injury and increased fluid permeability into the lung. So the short answer, and probably the best answer, is to follow the trend in whatever marker you're concerned about. And if it deteriorates consistently over a short period of time, that's the time to intervene. And otherwise, try to stay away from intubation. If you can avoid it.
Okay, so the most important thing is close monitoring for these patients. Yeah. Yes. The next question is for Frank. Dr. Frank, Professor Frank, what do you suggest a therapy to prevent the fibrosis process in COVID-19? Do you have any experience or any suggestions?
I wish I had an answer to that question. By the way, I've been answering, I think, almost 20 questions already online. Yeah. There were many questions. I've been typing and typing as best as I could. I'm still not entirely through all the questions, but some of the questions, I have to say, are really excellent questions. I just want to point out one thing before I answer the question you just asked. There have been a lot of questions about nebulized heparin, and I think that is great, and it probably is the result of my enthusiasm about this topic and my research. Let me please point out that it is still a treatment that is unproven at this point in time. We are doing the research. The early results are promising, but we had lots of other early results that were promising, and then we found out that it doesn't work. So please, let's wait for the randomized data that we are generating. I know it can't come quickly enough for all of us, but we have to wait until we have the proper evidence before recommendations can be made in terms of using nebulized heparin. So don't put everyone on nebulized heparin now. It's promising, but wait for the evidence, please. That's one very important message, and I apologize for maybe being too enthusiastic about the work that we're doing. In terms of trying to prevent fibrosis in COVID ARDS or non-COVID ARDS, I think that's a very difficult question. And to be honest, Professor Marini knows much more about this than I do. And he may have a few words, after I've tried to answer this question. I think there are many different treatments that have been tried in the past, in the long past, in the recent past. I think the steroids in COVID have a clear role. The role of steroids in COVID is not necessarily preventing fibrosis, but it improves outcome, it improves mortality. So it does something to that inflammatory process that's happening. And maybe it will, because of that, it may reduce the fibrosis in the late stage as well. So steroids have a distinct role just because it improves outcomes, not necessarily with the target of reducing fibrosis. There have been other studies and other particular attempts to reduce fibrosis, both in COVID ARDS and non-COVID ARDS. And as far as I'm aware, but again, I would like to hear from John as well, as far as I am aware, there are no specific treatments that work. There's a lot in the pipeline. There's stem cells. There's other drugs that can modify some of that inflammation. But as far as I know, we don't have a great magic bullet for that. John, can you please help me here?
Well, Frank, first of all, I think you're being entirely too polite. I don't know anywhere near as much as you do about this area, but I think we could both agree if we could minimize the inflammatory process in whatever way is appropriate. Now, that may be prevention of a secondary bacterial infection. That may be keeping the vigorous breathing efforts to a minimum. Reducing the minute ventilation requirement, keeping adequate PEEP, but not extraordinary PEEP. And I as an old-fashioned physician, I do have confidence that the steroids are helpful. I'm going to digress just slightly about the steroids and say that we have been side-railed, as we say. We have been deviated from the right path, I think, in ARDS by early studies that suggested that steroids don't work, but it's dose dependent, it's duration dependent, it's phase dependent. As we learn more, we understand that steroids really should be considered in many forms of ARDS, and I think that COVID-19 is just the most recent spectacular example where we have a whole bunch of patients coming in at the same time with ARDS, and we can actually see that some of these people are getting rapidly better. I'll stop there. As I say, I don't know as much about it as you do.
Thank you, John.
Okay, so I think it's the most important thing is reduce the inflammations and prevent the further lung injury, I think, yeah. Mm-hmm. So the next question is for Dr. Rohit. In terms of the fluid therapy, especially in COVID-19 patients, do you suggest any special considerations for this kind of patients, since these patients also shows like vascular leakage, or is there any place for giving the albumin 5% or 20% in these patients?
Yeah, thanks for the question. So as I mentioned, albumin, just low albumin should not be an indication to give albumin to this patient, or rather any patient with sepsis or septic shock. COVID-19 patients, I would say, they have a little bit of different pathophysiology, and we know 30% of them do enter into, if they remain in the ICU long enough, they may develop AKI. But we also need to be mindful that these patients are having insensible losses in terms of high-grade fever. They are working very hard from the lungs. Okay, so we need to be optimal in terms of fluid management for this patient. So again, where is this patient? Which kind of patient we are talking about? We are talking about those less than 5% patients who are in the ICU on ventilator. So they should not be treated differently in terms of fluid management as compared to any other patients with an ARDS or sepsis while they are in the ICU. So I'll be using fluid responsive or responsiveness, or looking for their response to the fluid boluses and see whether they are responsive, and then optimize their fluid accordingly rather than just flooding them with the fluid. In our institution, we had sort of we use low dose inotropes to keep them a little bit on the drier side, just to facilitate the oxygenation and prevent any harm to the lungs. Okay, but at the same time, we don't let them to be too underfilled as well, so as to prevent development of AKI in this patient. So that has been our strategy in our institution. So I would say that still using conservative fluid management with low dose inotropes may be still useful in this patient.
Okay, thank you. So there is another questions for Professor Marini. So for improving the oxygenations without further injure the lung, do you suggest we should do early prone position in very severe hypoxic patients? How do you suggest about early prone positions?
Well, I think it's an unsettled question in some sense, but certainly if you're using peak levels that are greater than about 8 centimeters of water, maybe 10 at an upper limit, and you're still not getting a satisfactory oxygenation response, or the patient again is deteriorating, I would prone that patient very quickly, especially if their ventilation requirements are high and you're right at the borderline of what might be causing ventilator-induced lung injury. I think there's so many questions that are totally unstudied, and it's only opinion. And my opinion is no better, I think, than many experienced clinicians in that regard. But prone positioning really makes an enormous difference in some patients in any form of ARDS. And I'm very convinced that in very severe cases, patients will strongly benefit and may survive when otherwise they would succumb to the disease. Can I follow up on one question about the albumin?
Okay.
Dita, is that okay?
Say okay.
Yeah, Rohit, at least in theory, early on, these patients might be even more leaky in the lungs than you might envision a standard ARDS patient. And later, they may be less leaky because of microthromboses and so on. It's been a long-standing controversy whether albumin should be used in ARDS because it can leak into the lung and, retain water in the lung and so on. But maybe, again, it's phase specific, whether or not albumin is dangerous or not. What's your opinion on that?
No, so as I mentioned, definitely there are different phases. Where we catch these patients, that has to be assessed and individualized. There are recently, I think, thromboelastography recently there is transpulmonary techniques which are actually looking at the total lung water and actual amount of fluid in the extravascular spaces in the lung can be used as well to optimize whether whether fluid you are giving is going into the right spaces or not. I believe in early phases there is still a component of decreased hydrostatic pressure, and it depends on which component is more dominant in causing hypotension or the shock in those patients. The fluid therapy should be guided accordingly. If the hydrostatic component is still there and patient is requiring high amount of inotropes, especially noradrenaline and vasopressin, I would say that squeezing a dry vessels may be more harmful than good in those patients. So I would still give a judicious amount of fluid in those patients with an anticipation that these patients will continue to leak, and little we can do about those leaky syndromes at this point in time. But if patient is maintained in that phase and we are able to deliver optimal oxygenation, so once that phase is out, then we'll be aggressive in terms of removing that fluid. And usually I use a marker of my fluid responsiveness as a guide to remove my fluid as well. And I will give a gentle dose of, after 24-48 hours, I will give a gentle dose of Lasix and see if there is any change in stroke volume variation, or there is any variation in the arterial line. And if there is not, and then I will go on full throttle in terms of removing those fluids. But I agree, it is. But again, I don't think so. We can use that as a to give more albumin, because it's not going to be retained and it's not going to cause any benefit in those patients. So I use albumin primarily as my de-resuscitation phase. Thanks. Thank you.
Thank you, Dr. Rohit. So another question for Professor Van Haren. In terms of giving nebulized heparin, should we add another systemic anticoagulation still in our COVID patients?
That's a very good question. I'll start by saying again that we should not give nebulized heparin just yet. We need to wait for the evidence. But what we've done in our studies so far, and also in the case series, is that yes, people receive their normal anticoagulation as they normally would get. So if you give prophylactic heparin or low molecular weight heparin to your patients, you just do exactly the same. So the nebulized heparin, and that's one of the things that we've shown quite well now, does not have an effect, or hardly an effect, on systemic coagulation. So, for example, when you measure APTT, you need to give a huge dose, something in the order of 150,000 units, before inhaled heparin will affect the APTT. And the dose that we're talking about in our studies is 25,000 units per dose. So the threshold dose to get a real effect on the APTT is much, much higher than what we use in our studies. So that doesn't mean that we don't see any effect on the APTT in our studies, but we see an effect on the APTT, and the APTT still stays in the normal range. So there is no overshoot or no systemic anticoagulation when you inhale heparin for this indication. So yes, so you should give your normal prophylactic or therapeutic anticoagulation as you normally would do, even if you use nebulized heparin as a COVID treatment, which you shouldn't do just yet because we need to wait for the evidence.
Thank you. Thank you for the answer. So another question, I think it's believed to be addressed to Professor Van Haren again. What is the time to give tocilizumab in your experience? And do you have an experience for giving the IVIG in COVID patients?
There were at least 10 or 12 questions about IVIG and also
tocilizumab.
Tocilizumab, interleukin-6 inhibitor. So I think the interleukin-6 story is slightly complicated because the original observational studies showed a possible effect, and then the randomized studies didn't show a convincing effect. Now, we are awaiting the most recent one that we've already seen some data suggesting that there may be a subgroup of patients that it could be beneficial for. But to simplify things at the moment, I think when you combine all the evidence that's there on that drug, there is no recommendation to give this to all your COVID patients. So, we're still waiting for some of the studies, but right now it would not be recommended to give it to all your COVID patients as an effective treatment. I didn't expect so many of these questions because I was assuming that this is one of these drugs that are relatively expensive and may not be widely available in a lot of countries, including in Indonesia. But I was clearly wrong, because there have been many questions about toxicity. I can't pronounce it. That's also why I wouldn't give it. I can't pronounce it. Some people say they pronounce the C as a K. I've heard some American people. How do you say it, John?
Just the way you did, Frank.
Toki.
Frank, can I ask you a question?
Yeah, of course.
Zita, can I ask Frank
Yes.
a question? Okay. In systemic anticoagulation, do you follow as a marker, D-dimer or coagulation products to decide who to fully anticoagulate? Clearly that's one of the strategies that's been out there for a while.
Yeah. Look, that's a very good question, John, and a very difficult question. I think we all agree that there seems to be a subset of patients that have incredibly high D-dimers and fibrinogen levels. So intuitively, we think those patients are at much higher risk of thrombotic complications or just general poor outcomes for COVID-19. We know that patients with high levels have worse outcomes. But whether that means that you can individualize your treatment based on D-dimer or fibrinogen, as far as I know, there's no evidence when you do that you then improve outcomes in a subset of patients. So it makes a lot of sense to individualize treatment based on that, because those patients are at higher risk. But it's not been shown then to improve outcomes in those patients. So I think that would still be, in my view, experimental. It's certainly one of the things that we're looking at as well in our studies. Can we identify patients at higher risk who could potentially benefit more from nebulized heparin? But I think to simplify the approach, and certainly for at a global stage and for low and middle income countries, to simplify the approach, I think anticoagulation should be based on the main anticoagulation studies. So REMAP-CAP, do not anticoagulate your patients with therapeutic heparin when they are in intensive care, unless you have a recognized indication for therapeutic anticoagulation, such as a pulmonary embolism. Because if you do it in all your patients, you get not better outcomes, but you get more bleeding and more bleeding complications. So that's one part. And then you don't have to worry about D-dimer or fibrinogen in your hospitalized patients, not mechanically ventilated, not in intensive care. It's very likely that there's going to be a benefit of therapeutic anticoagulation based on REMAP-CAP, but we need to wait for that data to come out peer-reviewed. But I think that might be a practice changer, a game changer. But at the moment, again, all people should be on prophylactic. There's not a specific subgroup that I would treat differently. And if there is a recognized indication to give therapeutic doses of anticoagulation, such as a DVT or a pulmonary embolism, then they just should get their normal therapeutic anticoagulation. Is that how you approach it as well, John?
Well, if you have, almost everyone gets some dose of prophylactic anticoagulation, and the transition to full anticoagulation is deferred until, following D-dimers, which are simple and inexpensive. If that begins to escalate, then that may be the signal to convert to careful full anticoagulation. Yes, in a big study, you'll find bleeding complications, I suppose, but actually in our practice, we seldom see any kind of major bleeding episode without a provocation that's fairly obvious. There's obviously some patients in whom it's contraindicated, but we've got to prevent these thrombotic events. I mean, so many case reports even have been registered where people are moved from the ICU, they go to general care, or they even go home, and then they die at home, or they die in general care because of clotting complications. And I think the risk-benefit ratio really favors monitoring and then anticoagulating. But you know, I admire people who can do randomized clinical trials that really give a decisive answer, because so many of our trials have been inconsistent. When I say inconsistent, I mean non-definitive. You know, they come out with, "Oh no, we can't find any full signal," and then we find a subgroup, and then we have to target that subgroup in another randomized trial. That's the right way to do it if you've got infinite time, but most people want to get faster answers.
Yep.
Sorry, I mean that's just that's just my experience anyway.
Dr. Rohit, maybe you want to add some suggestions about it?
No, I think our therapy is also the same in terms of managing this COVID patients. Unfortunately, number here are quite low and under control, and especially in the ICU per se. But I think there are always been issue in terms of when to intubate, proning works or not, and in terms of all this therapy to see then anticoagulation. And there is within this small country also there is a lot of variation in the practice and difficult to convince that one therapy over other works. What I'm worried about is the extrapolation of this data to the other ARDS patients. And then wrong interpretation of this therapies, like proning non-intubated patients and giving anticoagulation or heparin nebulization in other group of patients. So I think that is probably something we need to be careful about, because not all ARDS that comes to ICU at this point in time are COVID as well. So we should not be extrapolating this data in the management of those patients. So I think that is something we need to be really mindful about. Thanks.
Thank you. Unfortunately, our time is up. So I summarize from our sessions. So I think it is encouraged to the clinician to routinely monitor the patient's respiratory drive and effort, and to adjust the ventilator such as PEEP, driving pressure, to achieve the physiological level of the ventilatory effort, and to prevent the further of lung injury. And I think a lot of pharmacological and non-pharmacological treatment for COVID patients, but most of the treatments still need further research and observation for their efficacy, I think. And an optimal fluid administration, it is important to ensure the tissue perfusions in septic shock patients. So at the end of our session, we would like to thank all the participants and all the speakers for their time, especially John, and the knowledge for these very informative sessions. And we're also looking forward to meeting you all again in the next Anesthesia Symposium next year. So please stay safe and healthy, and goodbye for everyone. Thank you.
Thank you very much.
Yeah. Bye-bye.
Thank you. Bye-bye.
Thank you, Dr. Dita. I would like to also thank Pfizer Indonesia for sponsoring this event. Also, thank you, Dr. Frans Pangalila, for giving the previous lecture. Thank you, John, for staying awake with us.
I'm not awake anymore, Krisa.
So don't forget, after this, I will present to you music. So don't leave the link. I'm going to
leave it for Dr. John.
Frank,
Thank you.
Rohit,
Thank
and
you,
John.
Rohit, Frank, thank you, and stay healthy. Hopefully, we'll see each other again next year in a better condition.
Thank you.
Thank you.
Bye.
Take care. Bye-bye. See you.